We're now moving into a part of bone disease called the metabolic bone diseases. And really, it's osteoporosis, osteomalacia, and Paget's disease. So here's osteoporosis. Now, this, these slides reflect an older thinking of osteoporosis, that it's calcium is, is the problem. But really, uh, what it the the newer thought on it is that um, what's going on is that osteoblastic activity of normal bone remodeling falls behind osteoclastic activity of normal bone remodeling. That somehow bone is being removed faster than it's being replaced. And this could be due to declining osteoblastic function. It could be genetically predetermined. It could be that osteoblasts aren't being stimulated to do it. And that by Wolff's Law, we know that osteoblastic activity depends on mechanical stresses placed on the bone. And so a lack of mechanical stress can lead to this. Um, there seem to be hormonal factors. Uh, the sex hormones, testosterone, estrogen, seem to play an important part in stimulating osteoblastic activity. And so postmenopausally, osteoporosis can be a problem. Um, young bone tends to remodel better and respond to mechanical stress better than older bone. So osteoporosis is often associated with aging. Um, Poor nutrition and calcium intake may play a part in it, but not as big a role as what was previously thought. Uh, Personally, I think that a lot of that was wishful thinking, because calcium supplementation is a fairly easy thing. And there's still an awful lot of people out there that you'll meet that that say, "Well, I can't have osteoporosis. I take calcium all the time," and it's like, no, it's all you have is expensive poo and expensive urine. Uh, so it's a multifactorial thing again. Um, a lot of people have osteoporosis. Uh, Now, the osteoporosis uh, can also be, so it can be a primary problem, uh, where that is the problem because of genetic or other factors or hormonal factors, but it can also be a secondary. It can be secondary to other diseases, other medical conditions, to various cancers and that kind of thing. But it also, there's an awful lot of people that are on steroids, that on prednisone, and and that can lead to osteoporosis. So that it's really kind of a nosocomial, uh, iatrogenic sort of cause. It's a side effect of prednisone, and my standard line here is that in Canada, people get a prescription for prednisone for their 65th birthday. It seems that there's an awful lot of our senior population are on prednisone because it's a very effective anti-inflammatory. But what prednisone does is it causes your body to your liver to undergo gluconeogenesis, and uh, and basically it takes proteins and turns it into sugar. And the protein that it takes is collagen, so that's the osteoid of bone and the adventitia of blood vessels and the and the dermis of the skin. So people with this secondary osteoporosis to prednisone. Also, will have thin skin, bruise easily, and probably have high blood sugar too. Does that sound like a fair number of our elderly population? Women are 4 times more likely to get it than men, mostly because of because of a number of factors. One of the factors seems to be hormonal, and so menopause seems to be a big part of it. But another part of it is that kind of bone density is like money in the bank, and you have to put it in when you're young. And so if you start out with more bone density at age 25, you will have better bone density at age 65. It just kind of goes with the territory. Now, 60 years ago, women didn't exercise the way they do now. The best way for a 70-year-old woman to not have osteoporosis is to exercise when she's 20. So you guys should take that to heart. It's something that you can improve your later years with by doing it now. The other thing that women have is that childbearing is kind of hard on bones as well, both hormonally and physically for calcium. You know, producing milk is more difficult for calcium. Now, before it becomes osteoporosis, it can be this thing called osteopenia, and that may or may not show any symptoms at all. It's usually something that they pick up on X-ray or on bone density scans, which are just scans looking for this. So generally, bones get denser through your teenage years, and in your 20s, they kind of level off, and they stay that way for quite some time, and then 50s and 60s, it starts to decrease. This slide says calcium consumption may have an influence, but so do other factors. I would suggest that calcium consumption is a fairly minor factor in this. The more that we find out about it, exercise habits, medications, mood, how you handle stress, because stress releases cortisol, which causes gluconeogenesis, so it's the same sort of thing as the drugs. Other diseases all play a big part. Hormonal disruptions play a big part. Vitamin D seems to play a part. The suggestion now is that a lot of people don't get enough vitamin D, and so really need to supplement with vitamin D. And that just aids in calcium absorption. They say that coffee and sodas, colas especially, play a part in it. Alcohol, smoking, eating disorders, all of those things play a part in this. So again, you're getting sick of it being multifactorial, but these metabolic bone diseases are another example of multifactorial things. It seems to be that white people, Caucasians, are more susceptible. So there's probably some sort of a genetic component to it. So the osteoblasts and osteoclasts really are under hormonal control. Uh, they're also so calcitonin plays a role. Uh, those sorts of things. Um, Most of the activity in bone remodeling takes place in the trabecula, and oftentimes this is the first place that we start to see this fragility of the bone, uh, and it can lead to things like compression fractures, etc. Uh, so these these spongy bone areas are more susceptible. So there would be things like the vertebral bodies, the proximal femur, um, the proximal humerus seem to be more at risk. So when you look at an X-ray, the it almost looks clear. The vertebral bodies, in this case, look like there's nothing in them. And you can see that some of the compression fractures, like this vertebrae here, is supposed to actually look square, more like this one, and it definitely doesn't. So that's quite a bit of osteoporosis. And these two shots, the healthy bone is, and this is a femoral head. You can see the fovea capitis here. Is This is the healthy bone on the left of the figure, and on the right is a typical osteoporotic bone, and you can see just how much weaker that looks. So early in osteoporosis, there's really no signs and symptoms. It's fairly silent, but later what starts to happen is you get collapsed vertebrae, compression fractures, loss of height, hyperkyphosis, easily fractured hips, various pain, slow healing of fractures. It makes it very difficult. It's one thing if you're 25 years old and break a hip playing volleyball. It's another thing if you're 75 years old and you break a hip. You may never recover from that. So in Canada, we screen for this. You can go get osteoporosis screening, bone density tests, ultrasounds, CAT scans, X-rays. Really help look for this. Now, the treatment options are really all fraught with difficulty. One of the things that was very common for quite some time was hormone replacement therapy, because they thought, okay, the problem here is hormones, is estrogen, and so let's give postmenopausal women hormone replacement therapy. But it hugely increases the risk of stroke, especially in smokers. So it's like, okay, you're robbing Peter to pay Paul. You're helping the osteoporosis, but creating other issues. The bisphosphates, the common one is Fosamax. Now, it actually increases bone density, but at a poor quality bone. One of the things about bone remodeling is that you remove old, worn out bone and then replace it with new, fresh bone. And what these do is they inhibit the osteoclastic activity, the removing of bad old bone, and what you'd end up doing is you lay new bone on top of kind of bad bone, and what you end up with is bone that's not as healthy. And there's some pretty nasty osteonecrosis issues that can happen with the extended use of these drugs, the Fosamax. One of the things is called fuzzy jaw, and we'll talk about it later when we talk about osteonecrosis and things like that. But it happens that the bone placed under mechanical stress is the bones that have the most problem. They have poor vascularization and that kind of thing, and so kind of at the roots of the teeth is the problem, and the bone actually dies and kind of just rots. It's it's a problem. The selective estrogen receptor modulators seem to be of marginal value. I haven't heard a lot of good reports on that. So I think that they probably work well with some people, but maybe not with others. And they're probably useless in men. Exercise is your big thing. And it's got to be weight-bearing exercise. It has to be exercise that actually stimulates bone production. The problem with it is that a lot of people already have bone issues and other issues by the time they actually get this diagnosis, so exercise becomes difficult. Diet, calcium supplements, all are part of the equation. Maybe slow the progression. It's hard to reverse at that point. Avoiding things that actually pull calcium off the bones, things like coffee and alcohol, are probably a real good idea. So whether you massage them depends really on the resiliency of the patient. Now, I also want to talk about a related disease called osteomalacia. Osteoporosis is the removal of the osteoid, of the collagen, and therefore there's nothing for the calcium to go on, and the bones get thin and brittle. Osteomalacia is the defective mineralization of bone. So the osteoblasts are laying down proper osteoid in a proper matrix, but it's not being properly mineralized. And that's what we were, that those first couple of slides seem to be mixing up. Now, osteomalacia, which literally means sick bone, it's I'm just looking here, on page 653 of your textbook. So, well, in osteoporosis, the bones get brittle because there's enough mineralization but not enough osteoid. So if it's reinforced concrete, there's not enough rebar, there's too much concrete. Osteomalacia is not enough concrete and too much rebar. So it's a progressive disease, and the bones get soft. So it's just insufficient mineralization. It's usually the result of a lack of calcium absorption, a lack of vitamin D, or a phosphate deficiency. When this happens in kids, it's a disease called rickets, and it used to be much more common than it is. So there's two primary causes of osteomalacia. One is insufficient intake of calcium, insufficient absorption of calcium, and the other is too much renal removal of calcium. So either there's not enough calcium because you're not taking enough in, or you're pissing too much away. Um, so, um, so there it can be a problem of the parathyroid gland as well. It can be the problems of hyperparathyroidism. Um, so that can add to it. So they used to call rickets, they called it the Englishman's disease because it was common in England, and then it became very common in Canada and Russia, and now we don't tend to see it here as much. And the reason it was so common was because of our weather and the way that we dress our kids. It's pretty hard to synthesize vitamin D when you've got a toque down to your eyebrows and a scarf up over your nose, and every square inch of skin is covered, and this, the sun doesn't come up until 8 o'clock in the morning, goes down at 4:30. It's very hard to synthesize vitamin D. So it was a problem. Now, that problem has been solved by they fortify bread with vitamin D, and they fortify milk. You can hardly buy milk in Canada that doesn't have vitamin D added to it. We have lots of vitamin D supplementation as well. This So we tend to not see it. We tend to see it more in immigrant children that maybe are suffering from calcium deficiencies in dietary deficiencies. In adults, housebound people that are have diseases that keep them inside, or institutionalized people that don't get outside enough, may actually be at risk for this. People with like celiac disease, people with malabsorption syndromes have this problem. People with bulimia or anorexia seem to have or often have problems with this. So what happens with these kids is they end up with bowed legs and problems in their ribs and things. Those are the things that you see the most, because the bones get soft and the weight-bearing bones really can't support. So they start to miss shape. And like I say, you don't often see it here anymore, but in my grandparents' day, your great-grandparents' day, you would have seen a lot more of it.